Good day, my dear students. Welcome to R.A.T.S for Postgraduates. The topic, or rather, the series of topics that I shall be taking from the recent advances shall be from the recent advance 25. And in this, a good number of manifestations of COVID-19 have been included. So it's better that we are cautious and well prepared in the beginning itself. This particular article is regarding the hepatic manifestations of COVID-19, a clinico-pathological review. These are the authors over here, and we shall now go to the topic proper. I've taken immense pain in preparing the pictures, downloading the relative pictures as such, and also corroborating it with the text that is available. This is the normal histology. Normally, we know that this is a hepatic lobule over here. Very beautifully, it has been shown. These are the portal triads at the alternate angles. And there are the three zones on a lobule, a central vein. And around the central vein, we have got zone 3. Around the portal triad, we'll be having the zone 1. And intermediate will be the zone 2. Also, I find that there will be the hepatic artery, the portal vein, and the lymphatics at the triads. A beautiful schematic picture. And this again is a histoanatomical diagram in which I'm able to see the radiating cords of hepatocytes around the central vein. And there are the sinusoidal spaces which are seen. Look at the definite architecture that is well made out. Vesicular nuclei, polygonal cells arranged in strands. Yet another picture of the same, showing the importance of the hepatic lobule. And when I go to a particular ribbon of the hepatocytes and the sinusoids, these will be the hepatocytes. And in fact, you find that there are intracellular or intercellular modes of transmission of bile. And this is the sinusoidal spaces, which is being lined by the fenestrated endothelium. Also, you find that there will be the biliary canaliculi and the ductule. This particular topography we should have in mind for any of the liver pathology. If we have not understood it adequately, look at this beautifully restructured diagram that they had drawn. It is from the net, of course. So this is the portal triad over here, showing the artery, the vein, and the lymphatics. The yellow ones are the cords of the hepatocytes, and the red are the sinusoids. After all, sinusoid is blood. So it is being depicted red in color. For each and every color, they have spent their time, imagination, and knowledge. There can be the lining phagocytic cells, namely the Kupffer cells. So we shall be having these in mind before we go to the topic. COVID, it is not new. And they say the COVID-19 is supposed to be a variation of an earlier version of the COVID. So this is called as COVID-2, SARS-CoV-2 and COVID-19 because it appeared in the year or emerged in the year 2019, in which more than 50 crore cases have been identified, resulting in 60 lakh deaths. Of course, all of you people know what kind of a pain and a stigma it has been to the entire world and the perils of it. Coming to the pathology itself, the complications can be pulmonary complications, gastrointestinal, and the coronavirus itself can be targeting multiple other organs, including the hepatobiliary system, which we are going to see in this class. Before that, always a general word of the manifestations of COVID-19. There are two forms of this. Basically, it is supposed to be a disorder causing an immense respiratory distress. So this is one. And there are the other systemic manifestations such as fever, fatigue, cough, headache, hypoxemia, lymphopenia, and cardiac injury. This is one. And this is the other, sneezing. And there is one called as RNAmia. So the RNA gets affected, there is a paucity of it leading to a decrease. Just like anemia is absence of blood itself. Pneumonia, rhinorrhea, sore throat. Ground glass opacities is again a common term that can be used for any of the viral infections. Go back to hepatitis B virus, you will be finding the ground glass opacity within the hepatocytes. And respiratory distress syndrome is always coexistent with any of the systemic disorders. This is a beautiful depiction again. The source of it is given over here and nothing is my own. So it is an ultrastructural morphology exhibiting the coronavirus. The spikes outside the virus include the virion. And this is supposed to be a schematic picture of the virus that we see under the electron microscope. And it is called as novel coronavirus because it is something new. And this history and all you people know, Wuhan in China, 2019. Now, students, this is an extremely important slide. And I have got regions such as the lungs, the blood, drugs that are being used, the GIT, and the heart. Also, I find that there are different arrows pointing to the liver. What does this particular chart show us? In the lung, for example, there can be a severe hypoxia, inflammatory cytokines, and endothelial activation. Also, I'll be able to see that there is the procoagulation that happens and microthrombi that are being formed. The hypoxia leads to diminished amount of blood and then a reperfusion, which can lead to a necrosis. So also the microthrombi. Similarly, I find that there can be the microthrombi that can be formed leading to obstruction, and there are various drugs which can cause a hepatic injury. Lower down, there is a gut barrier disruption in which the bacteria or the viruses are being released and leading to a hepatic damage. Also, the viruses in the blood can lead to an infection of the cholangiocytes and its damage. Ultimately, there can be a change in the enzymes, etc., which can result in the diagnosis of a liver disorder. And in the myocardium also, there is an elevation of the expiratory pressure, mechanical ventilation, again leading to hypoxia. So this particular chart, I would like you people to remember, this concept will be repeated n number of times in the slides to come. For example, in this one. So this is a virus. The spikes are seen over here, and this is called a virion, a viral particle, which infects the hepatocytes. Also, it can be coming to the liver by means of the GIT and the other regions that I had shown. Now, what is important in any of the viral pathology is it cannot multiply on its own. It needs either the host RNA or the DNA. So the viral particles having gone in, this is the nucleus of the host and this is the cytoplasm. You find that it gets incorporated in the chromosomes of the host, and those will be undergoing a multiplication. And also you find that there will be a release from the regulatory mechanism. There is a continuous proliferation leading to a release of the viruses there. After which, there is a lysis of the cell and it uses the same cell membrane for the recapitulation of its wound. And a virus is reconstituted, it is getting released to infect more cells. This particular explanation, I would like you people to write even in an answer on HIV and so on. Now, the methods of diagnosis are given over here. I shall be repeating them. Now, what is important is ultimately there will be the SARS-CoV-2 that is entering and then being released from the liver tissue. Also, you find that there is something called as upregulation of interferon. These two things are important in this slide. The rest of it we people can see later on. And this is an incidental picture, not necessarily from a COVID-19 case. I find that there is a loss of architecture. Go back to the first picture. I'm not seeing the radiating cords of hepatocytes, the sinusoidal spaces, etc. There is, in fact, large as well as small vacuoles which are filling the hepatocytes, and there is a narrowing of the sinusoidal spaces, loss of the hepatic architecture, and probably there is some kind of an inflammation, a triaditis or a venulitis, and that is causing spurs of fibrosis. This is something that people should be having in mind. It goes hand in hand with the infection. This again is said, there will be a repetition. See what is over here. There is a liver injury in a SARS-CoV-2 infected patients. That is COVID-19, in which there can be an elevation of the ALT, GGT, bilirubin, and MCP1. Decrease in albumin. And what are the expansions? I have shown it over here. Aspartate transaminase and monocyte chemoattractant protein. That is supposed to be the expansion for this. Gamma glutamyl transferase and angiotensin converting enzyme. These things we shall and will mention in our answers. They are of great importance. Again, you can recapitulate the original pathogenesis. Ultimately, these can be the causes, which again I have shown in an earlier one. There can be a pre-existing liver disease, or there can be other systemic diseases leading to a hypoxia. There can be drug-induced injury, microthrombosis elsewhere, and ultimately you find that it happens to be multifactorial, and liver itself need not be the primary. It may be the primary under a liver disease, or it can be secondary due to a disease in some other system. Now, having said what are the causes and the mechanism of liver injury, what are we actually going to see? This is a series of changes that they had seen either at autopsy or in a biopsy, either of which were prohibited because of the contagious nature of the disease. But still, some research centers bore the brunt, took it on their shoulders, and did the study in which they had seen this particular list. They have done a great work. Let us at least memorize what they have done. There can be microvesicular steatosis. Whenever I use the word microvesicular, there can be a macrovesicular also. Steatosis is nothing but accumulation of fat within the cells and vacuoles. Sinusoidal dilatation. Nuclear glycogen. Glycogen can be either in the cytoplasm, in the nucleus also. There is a lobular and portal activity, that is inflammation, proliferation, etc. Foamy histiocytes are positive for the COVID virus. And there can be erythrophagocytosis in the Kupffer cells. Lung mechanism and manifestations are different, which is a primary for this. So this particular list we will have to memorize. Not only that, this list again I had introduced in this one because it is worth memorizing. If we are asked what are the investigations, it can be a PCR for detecting the circulating virus, ERCP, endoscopic retrograde cholangiopancreatography, immunofluorescence, in situ hybridization, various enzymes that we had mentioned. Also, there can be the other incidental findings such as cirrhosis or a nutmeg liver or liver cysts. So this is a beautiful projection which we shall memorize and score the marks. And Look at this wonderful study of it. Whatever we have said is being reflected in these pictures. Thanks to this particular reference, the authors, and this is the journal where it has been published. So here we find that there is a steatosis of the vacuoles, which are seen. And there is obviously an effacement of architecture. Also, I find that this can be found in other tissues, the vacuolation, etc. And in this particular case, there are the hepatocyte strands, etc. But still, there is a degeneration and a cell-by-cell death or apoptosis, which is being marked by means of this arrow, apoptosis. And there can be a portal triaditis or a venulitis, which can be seen. So kindly follow these pictures, very easy for you to recollect and write. Fibrin thrombi. Thrombi are extremely important because we did not know for what reason. At one end, in the beginning, they saw it was respiratory distress. But then, even without that, the patients are simply succumbing thanks to fibrin thrombi, which can occur on the pulmonary renal or the cardiac microvasculature, hepatic sinusoids, which can lead to ischemic necrosis, and also the portal vein, which can show large aggregates. There is a zone 3 necrosis. Zone 3 is around the hepatic central vein. Platelet fibrin with microthrombi and megakaryocytes are also seen. Why we do not know whether there is a growth factor or it is becoming active or is it extra medullary hematopoiesis. But whatever said and done, there is an increase in the megakaryocytes, and this is the figure that we people see. There is a marker for the microthrombi. CD61 is the marker. And there is a marker for the megakaryocyte and platelet, GP3A. This you people will be knowing. The COVID in a blood clot. As I told you earlier, it need not primarily be the liver that is affected, but it can be from the blood, and the liver can be showing secondary changes. The spikes can be very well appreciated. The hepatic involvement, the Journal of Medical Virology. So look at this one. There is a central vein around which there is an inflammation, and there is also a dilatation, a stagnation, which can lead to later on fibrin formation or an ischemic necrosis. And there is also a mixed inflammatory infiltrate. And it is not a chronic inflammatory process as hepatitis B virus. So there will be an acute inflammation also that is present. So vasculitis, inclusions within the cells, neutrophils, and the projections of lymphocytes. These people shall be remembering. Kindly explain from the picture yourself. Switch off my mic and then you try to explain. I always go by my promise. So this is a repetition. Repetition is the mother of knowledge. So you find that these are the hepatocytes. They are affected by means of the SARS-CoV, and there can be a cytokine storm. These are all the various mediators that can be released. This again, I'll be showing you people in a tabular form, which is easier for you to memorize. And you find that there can be the aggravation of the underlying liver disease. Ultimately, there can be an ischemia, hypoxia, and even a death. Also, drug-induced injury can be there. So all these things people will bear in mind. The roots of liver damage. We have been constantly mentioning the coexisting diseases. What are the coexisting diseases? It can be other liver disorders, such as a hepatitis, a cirrhosis, etc. Diabetes mellitus, inflammation, fatty liver, alcoholic hepatitis, non-alcoholic fatty liver disease, and non-alcoholic steatohepatitis. These can be coexisting diseases. And there can be overlapping findings in the hospital patients. So whenever we do an autopsy, it is not going to be a pure production of that particular disease alone. There is going to be a lot of this overlapping. For example, there can be a superadded infection, or there can be an underlying cirrhosis, or there can be a manifestation of diabetic fatty liver. So all this should be borne in mind. Patients with a transplant, they have got their own curse. There can be neutrophils, edema, sclerosis need not be present, and a picture of acute hepatitis is constantly seen. So again, a transmission electron microscopic picture in which you find that within the cells there can be the viral inclusions. So he says that the blue colored ones are the viral particles in which you will be able to see the black granules. Liver biopsy and mechanism of injury due to drug-induced liver injury. The drugs in this case can be prophylactic drugs, there can be therapeutic drugs which are used for the treatment of COVID-19 itself, and any other antiviral drugs. So the histological changes that people can be seeing is what we had mentioned earlier. In addition, there can be bile stasis. So this is important. Now, what are the drugs as such? So there's a list of drugs over here. All of us know remdesivir. And there is a long queue waiting to procure these drugs. This itself can lead to hypoalbuminemia. And also there is an increase in serum bilirubin, hepatic failure, hepatitis, all can be caused. So there can be toxic changes, whereas some drugs are better tolerated. This I would like you people to go through. And azithromycin, other things which are being prescribed for a period of 5 days are themselves hepatotoxic. This is all from the liver tox database. And the details can be found. There is also a liver impairment in SARS-CoV-2, 2003. So this is the ischemic necrosis that I've been talking about. So look at this one. So this is the Porter triad. This is the zone 1. This is being relatively spat. But whereas around the central vein and in the mid zone, I find that there is an extensive areas of necrosis. And when I say in the middle, this is a hepatic lobe or a slice of liver that is showing an area of necrosis. There are areas of congestion, a yellowish one can be the areas of fatty change, and there is also a grayish black areas of necrosis. So you can compare this with the livers elsewhere, and probably if you look very carefully, I can appreciate a nutmeg appearance in the periphery of the viable liver. What are the other laboratory findings? You are supposed to mention ALT, AST. These are the expansions, and also the angiotensin converting enzyme. There are markers such as keratin 7, and gamma glutamyl transferase, serum bilirubin. These can be the list of investigations. Apart from the viral infections, viral inclusions, thrombi, etc., you can also be using a. Dear students, this is an important master chart that we shall be remembering. Here are the list of the manifestations. And this will be the histopathology that we see, any special stain or IHC in this column, and what are the other considerations we should be having in mind. Fatty liver is one. Obviously, there will be steatosis, accumulation of fat, and trichrome stain can be used to demonstrate early fibrosis. And any of the cause for the fatty liver should be borne in mind. There is a vascular injury, microthrombi can be there, and CD61 is the platelet fibrin marker. Also, there can be hypercoagulable states which are associated with it. Endotheliitis, CD34 is a marker for the endothelium. And these can be the other causes for it. Macrovascular thrombosis. Again, it can be demonstrated by means of trichrome. We should be remembering venous obstruction and Budd-Chiari syndrome as a cause for thrombosis. Drug-induced liver injury, variable over here, and there can be a trichrome for fibrosis, and the drugs that are used for the differential diagnosis, the treatment of COVID also should be borne in mind. Angiopathy can be cholangiopathy, that is over here, can be because of sclerosing cholangitis. And these are the two markers which we should be having in mind, keratin 7 and keratin 90. And SARS-CoV vaccine associated can give a picture of chronic active hepatitis. Trichrome is again used to demonstrate the injury. and it can be seen in autoimmune hepatitis also. So please do remember, trichrome is the only special stain that we are going to mention, and there are two keratin markers, two CD markers. Easy for us to remember. So COVID-19 associated hepatitis. Directly, we are associating this as COVID-19 because there are no previous liver disease, no drug intake. And also you find that liver transplant in a COVID donor can also lead to hepatitis. Apoptotic hepatocytes, which you had seen earlier, acidophilic bodies, and also something like Mallory bodies that you people see, ballooning of the hepatocytes, and viral particles, drug-induced liver injury. These are the investigations and the findings, of course, fibrosis, ductular reaction, a proliferation of the ducts. This is very common in any of the liver injuries. On one hand, there will be an obstruction of the bile ducts, etc. And on another hand, there will be proliferation. So rule out these: direct injury, ischemia, and any toxic bile. So this diagram again explains it. It is a little more complicated for us. We shall not bother about it. So this will be the cholangiocyte or the endothelium that is communicating the bile over here. And there are the various mediators such as the cytokine, interleukin 6. And what is this? We shall be seeing. Claudin 1 is 1, and this is ASBT, apical sodium dependent bile acid transporter. God alone knows why all these are there. You people may mention it or may not. But then please have it in mind that a lot of work has been done in the COVID, and the liver is one of the fulcrums of it. Sepsis. And these can be the various mediators which are produced in it. There can be the fibroblast growth factor, then granulocyte monocyte colony stimulating factor. These can be the sources of it. Angiogenesis can be from the vascular endothelial growth factor and reactive oxygen species. These are all common in COVID. And in sepsis, we should bear in mind it can be because of the vaccine also, in which there will be reactive changes, hypersensitivity such as eosinophils. It can be responded to by steroid therapy. Strangely, you find that it is a double-edged sword. People are suffering and dying because of infections. And also you find that steroid is a wonder drug for treatment. There can be confluent necrosis. We had seen that earlier, lymphoplasmacytic infiltrate, indicating plasma cells means there will be antibodies. That means there is an immune mechanism. And whenever there is a confluent necrosis, there will be a bridging fibrosis. All these can follow suit of sepsis. And these have been derived from this research. The conclusion is the liver injury is seen in COVID-19. Further studies are needed. We have seen only a few cases of autopsies, and these are the findings. And further studies will be needed. Probably with the newer outbreak, there will be more of things to come. And also it is multifactorial in origin. And these are the key points that people should be having in mind. Pharmacy is one leading to hepatotoxicity. There can be underlying liver disease. And cholangiopathy, sclerosing, cholangitis can be increased. Hypercoagulable states can lead to fibrin thrombi formation. Also remember the autoantibodies. Some people may be having, such as SLE, and they'll be having a super added COVID infection also. There's much pleasure to be gained from useless knowledge. I do not know how far it is going to be very important for us in our day-to-day application. But then definitely recent advance 25 is going to plague us in the university exam. I wish you all the best.